Bismillahirrahmanirrahim. Let's go through some scenarios. A 46-year-old doctor presented with complaints of loose stools, which are small in volume, which are associated with mucus, but there was no blood. It is associated with colicky abdominal pain. He has the complaint of 25 years now and has affected quality of his life badly. His appetite is good and he is otherwise okay. Vitals and systemic examinations are normal. What investigation will you advise to reach a diagnosis, and what is your provisional diagnosis? Let's go through another scenario. A 35 years old male presented with complaint of abdominal pain which is diffuse and vague and periodic with partial resolution in between for several months. Abdominal pain is present for a period of 10 years. He has severe constipation for which he has to use laxatives and stool softeners. Pain is partially relieved by defecation, which his appetite is good and he is otherwise healthy. Systemic examination is also normal. What is your provisional diagnosis? Here's another one. A 43 years old male presented with complaint of loose watery stools which are small volume and contains mucus but there is no blood. These are associated with diffuse and vague abdominal pain. He tells you that he has constipation before this for which he was using stool softeners. He has this complaint for several years now and is fed up with this cycle. Systemic examination is normal. What will be your diagnosis? Today our topic of discussion is irritable bowel syndrome. I'm Dr. Mohammad Zeeshan Aslam, as already mentioned in the previous lecture, and this lecture is by the courtesy of our professor Dr. Muhammad Hanif Nagrasa. Now, this is the feeling someone has when he has IBS. The quality of life of IBS patients is similar to patients with heart failure or depression. The impairment is greater than with diabetes. Irritable bowel syndrome is a functional bowel disorder which is characterized by abdominal pain or discomfort and altered bowel habits. Sometimes there is constipation, sometimes there is diarrhea, sometimes there is bloating, sometimes there is a mixture of all these in the absence of detectable structural abnormalities. The condition was first described in 1771. It was called spastic colon, and the patients with IBS are more likely to undergo surgical operations such as hysterectomies, cholecystectomies, and etc. International Foundation for Gastrointestinal Diseases established an art collection for patients suffering from IBS to express their feelings because it's very depressive type of disease and the patients usually are of type A personality, so therefore to express their this one. Pain, go away. That road less traveled is here, find it. Throughout the world, about 10 to 20% of adults and adolescents have symptoms consistent with irritable bowel syndrome. It is a chronic, relapsing, and often lifelong disorder. Prevalence peaks in the third and fourth decade, and it's twice as common in female as compared to male. The people most commonly affected are those between the age of 20 and 30 years. So the general physicians tend not to diagnose IBS but seldom miss serious diseases. So failure to recognize IBS is an important issue, and IBS patients are very likely to seek alternative medical care such as they can go to Hakims and Peers and all those. Approximately 30% consult general physicians, only 5% seek specialist help. So consider irritable bowel syndrome if someone has these symptoms for at least 6 months, which is A, B, and C, which is abdominal pain or discomfort, B for bloating, and C is change in bowel habits. Initial assessment. So consider IBS diagnosis only if the patient has abdominal pain that is relieved by defecation or associated with altered bowel frequency or stool form, and at least two of the following symptoms. We will also go through the diagnostic criteria, which is around three nowadays. We will also show you that criteria in the coming slides. So there is altered bowel stool passage, there is abdominal bloating, distension, tension or hardness. There are symptoms made worse by eating, and there is passage of mucus but no blood. So patient often comes and says, "Doctor, believe me, I was fat this morning." This is because of the abdominal distension, the blotting which causes. So abdominal distension is no more a myth. Some patients actually take photographs to prove that in the morning or sometimes they had the abdominal distension or blotting. This is the barometer. So abdominal pain or discomfort is a prerequisite clinical feature for the irritable bowel syndrome. Frequently episodic and crampy, but it may be superimposed on background of constant ache. The malnutrition due to inadequate caloric intake is exceedingly rare in irritable bowel syndrome. Abdominal pain is almost uniformly present only during waking hours. Always remember that the symptoms of the irritable bowel syndrome does not interfere when the patient is sleeping. They have a quiet sleep. They do not have abdominal pain. They do not have the feeling of bloating. They do not have the feeling of the diarrhea while they are sleeping. It's only when they are waking. It's often exacerbated by eating or emotional stress and improves by passage of flatus or stools. Female patients with irritable bowel syndrome commonly report worsening symptoms during the premenstrual and menstrual phases. No one day is the same. I might have diarrhea, and then there can be constipation, and then there can be a mixture of all these symptoms. So alteration in bowel habits is the most consistent clinical feature in the irritable bowel syndrome. The most common pattern is constipation alternating with diarrhea, usually with one of these symptoms predominating. At first, constipation may be episodic, but eventually it becomes continuous and increasing intractable to treatment with laxatives. Repeated attempts at defecation in a short time span. So the patient has to go to washroom, he has to sit there, he has to repeatedly go to washroom, and even if he wills it, there is always a feeling of incomplete evacuation. So he always feels that some of the fecal matter is actually still inside his intestines and that he wants to get rid of that. Diarrhea resulting from the IBS usually consists of small volumes of loose stools. Most patients have a volume stool of less than 200 ml. Nocturnal diarrhea does not occur in IBS. As already mentioned, it is an inflammatory disease that causes nocturnal diarrhea, not an irritable disease. So it's irritable bowel syndrome. So it will not cause nocturnal diarrhea. Diarrhea may be aggravated by emotional stress or eating. Stools may be accompanied by passage of large amount of mucus, but always remember there will be no bleeding. Bleeding is not a feature of IBS unless hemorrhoids are present or there is another cause. So bowel pattern subtypes, we already gone through them. There is IBS, which is constipation predominant. Then there is IBS, which is diarrhea predominant, and then there is IBS, which is mixed, or there is a mixture of constipation and the diarrhea. And 75% actually switch types usually between IBC and IBD, as already told you. So there is abdominal distension because of increased bulging or flatulence. Patients with IBS tend to reflux gas. Some patients with bloating may also experience visible distension of the abdominal wall. So they can feel that, and this causes the increased abdominal girth, which they actually use to take pictures. 5% of patients can also have upper GI symptoms such as dyspepsia, heartburn, nausea, and vomiting. What is the pathophysiology? So there can be gastrointestinal motor abnormalities, there can be visual hypersensitivity, there can be central neural dysregulation, abnormal physiological features, and post-infectious IBS, such as when it occurs after intestinal infections with Campylobacter, Salmonella, or Shigella. So immune activation and mucosal inflammation can be there. Altered gut flora is a theory. abnormal serotonin pathway, which is where there is excessive release of the 5-HT, and genetic and family learning. So in the diagram here, you can see as the time is passing, we are coming up with new and new ideas and new theories and hypotheses about the pathophysiology of the irritable bowel syndrome. So if you start from 1950, at that time it was thought that it's a purely psychological disorder. Then someone came up with the idea of abnormal motor function. Then as the time went through, visceral hyperalgesia, and then there is brain-gut interaction. Now we are in this era, and from 2000 to 2012, we are thinking about some genetic issues, some microbial mucosal issues, and then there is neuroimmune mechanisms such as the serotonin secretion and the proposal of post-infectious hypothesis. So for the diagnosis of the irritable bowel syndrome, because there are a wide array of symptoms, there is chronic abdominal pain with altered bowel habits. This is the main characteristic feature of the IBS. There are no biochemical markers, and this is actually a symptom-based criteria which we'll go through as well. So consensus statement of the American Gastrointestinal Association is the diagnosis of the IBS should be based upon the identification of positive symptoms consistent with the condition and excluding in a cost-effective manner other conditions with similar clinical presentation. The Rome criteria, which I mentioned earlier, provides a framework for identifying these conditions. Originally, it was created in 1992, and then later it was revised in 1999 and then 2000. This is the Rome criteria 3, which was revised in the latest one, which was revised in 2006. It states then there is recurrent abdominal pain or discomfort for at least 3 days per month in the last 3 months, which is associated with 2 or more of the following. So if a patient has abdominal pain, discomfort, diarrhea, distension for at least 3 days in a month for continuous 3 months, then we are suspecting him for irritable bowel syndrome. Now, if he has 2 or 3 of the following, then we can go for that. The improvement with defecation, those symptoms, the abdominal pain, discomfort, actually improves with defecation. The onset was associated with a change in frequency of the stool, or the onset of the symptoms were associated with change in the form of the stool. So the criteria fulfilled for the past 3 months with symptoms onset at least 6 months before diagnosis. So discomfort means an uncomfortable sensation not described as pain. So as already I have mentioned that you have to always rule out secondary causes or other causes, especially if in the history we find any of these red flags. Then before considering a diagnosis of irritable bowel syndrome, we must always rule out more sinister and more dangerous things. Because this is a diagnosis of exclusion, you have to rule out all the organic causes, especially if these red flags are present. Always reconsider your diagnosis of IBS. If there is unintentional or explained weight loss, if there is rectal bleeding, as I have already mentioned that there can be mucus in the stools, but there is never bleeding. Yeah, except when there are some secondary causes. If there is family history of bowel or ovarian cancer, then you have to screen for those before making the diagnosis of IBS. Bowel habit, if the change is for more than 6 weeks in a person of age more than 60 years, that is also a red flag. Age more than 60 years. If, as already I have told you, that is more prevalent in females, if a male comes to you, always recheck your diagnosis. If there is recent use of antibiotics, so it can be antibiotic associated diarrhea or something like that, so you have to reassess that. On examination, if there is anemia, because there was no blood loss and there was no underlying cause, so there should not be anemia, there should be no anemia. So if there is anemia, go for a recheck on your diagnosis. If there are abdominal masses, rectal masses, or if the inflammatory markers are raised, which will not be raised in irritable bowel syndrome, then you have to recheck your diagnosis. Factors that favor diagnosis are recurrence of lower abdominal pain with altered bowel habit over a period of time without progressive deterioration. So the patient has a same type of illness 4 years back, and now he has still the same symptoms, but he does not seem to lose weight. There is no anemia, there are no inflammatory markers, there is nothing else. So if the patient has all these and there is no red flags, and the patient is static with the similar symptoms, this goes in the favor of IBS. The onset of symptoms started during stress or emotional upset, and there is always absence of weight loss, fever, or small volume stools without any evidence of blood. So factors that go against the diagnosis of IBS is the appearance of the disorder for the first time in old age, as already mentioned. If age is more than 60 or something like that, progressive course of onset of time of onset, there is persistent diarrhea after a 48-hour fast. There is presence of nocturnal diarrhea, as already mentioned, that the patient will not have nocturnal symptoms, and if there is tutorial diarrhea. In people who meet IBS diagnostic criteria, the following tests should be undertaken to exclude other causes. So still they fulfill the clinical criteria, but you have to go for other some of the baseline investigations to rule out other causes, such as full complete blood count. If there is anemia, you have to look for other causes. Erythrocyte sedimentation rate, which is the SED rate, if it is increased, it means that the plasma viscosity is more and there is some underlying inflammatory disorder. CD protein is also an inflammatory marker. Antibodies against celiac disease should be tested. Endomysial antibodies or tissue transglutaminase should be done to rule out if there is suspicion of celiac. The following tests are not necessary to confirm a diagnosis. Where IBS diagnostic criteria are met, there's no need to go for extensive ultrasounds, rigid or flexible sigmoidoscopies or colonoscopies or thyroid function test, fecal ova or cystic parasitic test, fecal occult blood, and hydrogen breath test. There's no need to the treatment of patient counseling and dietary alteration. First of all, because the patient is having symptoms for such a long period of time, and they are type A personality, they are anxious, they have some emotional issues undergoing. There might be some emotional issues going undergoing. So the most important thing is to reassure the patient that this is not a sinister or a bad thing you have. This is not going to be a life-threatening disease for you. Okay. This can be an example of a symptom diary for IBS patient. They can mention the date, time, the number of stool passed, and what was the consistency of the stools. Whether was it hard, soft, or normal. Then bloating, abdominal pain if he has or she has, stress, any medication if she is taking, and then we can actually write down. The patient can write down the breakfast, lunch, dinner, or snacks he or she undertook, or if he has done some exercises. Meticulous history dietary may reveal substances such as coffee, disaccharides, legumes, cabbage that may aggravate the patient's symptoms. So the commonly used legumes include lentils, peas, chickpeas, beans, soya beans, and peanuts. Patients usually respond to initiating a low carbohydrate diet. So what are the FODMAP? We have to go for that. The fiber products and foods the patient take. Fiber provides a relief in IBS symptoms. Soluble fiber is of greater benefit. Unsoluble fiber such as from wheat or corn does not help at all. Fiber should be started in low doses and then it should be built up. These are the FODMAP diets. So with this is the fermentable oligosaccharides, disaccharides, monosaccharides, and polysaccharides. These should be avoided. So low FODMAP diets are better. There are several different types of short chain carbohydrates that make up the FODMAP family. The diet helps in 70% of the patients. A low FODMAP diet can be prescribed for patients. Then pharmacological. As it's said, the art of medicine consists of amusing the patient until nature cures the disease. So this is the placebo effect. And one third of the patients with IBS actually improve with placebo treatment. So the clinical management of IBS and pharmacological therapy, we have stool bulking agents, we have antispasmodics, antidepressant drugs, antiflatulence therapy. We can modulate the gut flora. There are SSR agonists and antagonists and chloride channel activators. Drugs for constipation are higher of each diet, such as isvogel husk, lactulose, or macrogols. Then we can go for duloxetine, relaxation therapy, biofeedback, hypnotherapies. We can go for that. Uh, there are some new agents, new drugs for constipation, such as lanaclotide. Its trade name is Linzess, and the trade names are given in the brackets. The generics are given outside the brackets. Lubiprostone and procalcipride. Antibiotics and probiotics. These cause a modulation of the gut flora. Now, these are actually targeting that theory which causes that there is some upset in the gut flora that is causing the symptoms of the IBS. So, rifaximin, which is an off-label indication for IBS, that can be used. Ciprofloxacin, which is an antibiotic that is used in patients with IBS without constipation, who do not have constipation. Treatment with rifaximin for 2 weeks provides significant benefit of IBS symptoms such as bloating, abdominal pain, and loose or watery stools. As we all know that the gut walls are made up of smooth muscles. So if for abdominal pain, if we use smooth muscle relaxants, that can actually lead us to a decreased state of spasm and pain in the abdomen. So hyoscine, meberberine, otilinomide bromide, dicyclomine, probenthine, and peppermint oil can be used for that. Antidepressants. Okay, antidepressants have a role, but you keep in mind that the patient actually had come to you with complaints of pain in the abdomen. And when you will prescribe antidepressant or some relaxating drugs to the patient, they will always question you, and this will make them more confused. Their anxiety and depression may actually worsen by knowing that they might be having some underlying depression or so like something like that. However, you have to consult the patient that no, sometimes there is some issues which you will not feel, but this abdominal pain can be related to your stress, your haphazard life routine. This can be because of that, and you have to consult the patient. So there we can use TCS, which is tricyclic antidepressants, or SSRIs, amitriptyline, desipramine, doxepine, imipramine, and nortriptyline. And then in SSRIs, we have fluoxetine, citalopram, and escitalopram. So if the patient has a predominantly diarrhea-associated IBS, you can go for a treatment of the diarrhea, such as loperamide. You can give it 2 to 4 milligram when necessary. Maximum to 12 gram can also be used. 12 milligram can also be used. Then cholestyramine can be used 4 grams with every meal. Olocitron can also be used. And then if it is constipation predominant, then you have to give a bulking agent, a stool bulking agent, so that the constipation is relieved. It can be there can be isopropyl husk or psyllium husk, or there can be methocellulose, calcium polycarboxyl, lactulose syrup, 70% sorbitol syrups, and other things. If it is predominantly abdominal pain associated IBS, then as I already mentioned, then smooth muscle relaxants can be used, tricyclic antidepressants, and serotonin uptake inhibitors can be used. So one of the other causes we have to actually go for, always try to ask the patient whether they are having a good sleep or not. A sleep duration which is decreased in time is also a bad sleep. And then there will be patients who will come to you with a normal sleep time. They will sleep for 8 hours or 10 hours even, but when they wake up they are not fresh. They do not feel that they have slept. They need more energy, they need more sleep. They will always wake up in a state of uh, fatigue. So feeling of sleep deprivation is common in IBS. And you have paramedical sciences which can help the patient with IBS because they are going through other things also. So massage therapy, yoga, spiritual therapies, and these pattern humor therapies, acupuncture, chiropractic things, they can actually help some of the patients. So if you have any question regarding irritable bowel syndrome, I'm always there to help you. My contact number for WhatsApp is there. You can contact me